that you see on screen now, and they perform complex and deformity surgery. So I'm thrilled to see what is Vassilis and Yanis prepared for us today. Please, Vassilis, start.
Thank you very much, Nikolai, for the invitation. It's a great honor, and thank you to the World Spinal Column Society. It's nice to see people working together, the north part of Greece, Thessaloniki, and the south Athens with Yanis.
What is the distance, Vassilis, between Athens
500 kilometers.
That's a great distance. And
Yes,
you still can work together. That's amazing.
And that's good with the planes. Anyway, I have to also thank Ed Benzel and the previous speaker, Ruli Hanafi, and the others for the cervical spine presentations. I don't know what minimal things I will be able to add to this day. Now okay. So cervical spine osteotomies are powerful techniques, and the goal of surgical treatment include deformity correction and achieving a rigid fusion and performing a thorough neural decompression, as very well was said today. I will start as an orthopedic surgeon with the SVA that was first presented in 2005, talking about femoral heads and pelvic incidents and pelvic and C7 SVA. And we know from the degeneration point that a young male will have the standard pelvic incidence with lumbar lordosis, cervical kyphosis, and extended knees. But then, as the years go by, the pelvic tilt will change, and the sacrum will rotate, and we will have an extension of hyperlordosis, and the muscles will be under stress. And then in a third stage, we will have the knees bended in order to fully rotate the pelvis, and the sacral slope will diminish, but still with the degeneration and the thoracic kyphosis, we will have positive SVA and global kyphosis. Then, sorry, I don't know how I will be able to go on. Okay. Then we have here the global spinal anatomy, which we included after 2012, the cervical spine. And so we all feel that global sagittal balance, it's still in its infancy. And we can see here the femoral heads with pelvic incidence and a pelvic tilt, and the global alignment from cranium or from T2. And then we can see different versions of kyphosis with hyperlordotic lumbar spine and very kyphotic upper thoracic, which continues with hyperkyphotic cervical spine. And we see here with kyphotic lumbar lordosis, complete pelvic rotation but and also hyperlordotic cervical spine in order to compensate, but still a global kyphotic posture. Let me remind you that anterior column in the cervical spine supports only 36% of the load, and the two posterior columns supports the remaining 64%. So we can understand how important it is in a deformity to treat the posterior facets. And we need to remember that C1, C2 cares for the 80% of the lordosis, like L5 S1, and the rest of the subaxial spine, cervical spine, C2 to C7, cares for 23% of the lordotic angle. So, as very well said by Ed Bensel, it's very important to take in consideration from C2, C3 disc upwards what is happening. And we have different kind of measurements as we have seen up to now. The thoracic inlet angle between the tip of the sternum and the mid of the T1 vertebra. The cervical tilt, which is the angle made by a perpendicular line from the middle of the T1 superior end plate and a line from the center of the T1 superior end plate to the tip of the dens. And we can see here a comparison between the cervical and the lumbar lordosis. The upper end of the sternum is considered the center of the femoral heads, and T1, like the sacrum. The thoracic inlet angle between the tip of the sternum and T1 is compared with the pelvic incidence from the femoral heads and the sacrum, and the neck tilt in comparison with the pelvic tilt, and the T1 slope with the sacral slope. They are both interrelated. So the cervicothoracic junction is between a highly mobile C-spine and a rigid thoracic spine, and it comes from lordosis and hypermobility to kyphosis and rigidity, and there is a significant amount of stress to the cervicothoracic junction. Now, if there is a small thoracic inlet, it will be a small T1 slope and a small cervical lordosis. And if there is a large thoracic inlet, there will be a large T1 slope and a large lordosis. So affecting the cervicothoracic junction is affecting the whole global sagittal balance of the cervical spine. And it can be a complete kyphosis of the whole cervical spine or a regional kyphosis. Let me move this a little bit further. And you can see that C3, C4, C5 has only kyphosis in this regional area. And also cervical deformity is part of the global spinal, but it can create regional cervical myelopathy, as well said. Very important for the improvement of the quality of life is to
Vassilis, I'm sorry to interrupt you, but by the looks of it, your slides are not moving.
You don't see moving it?
No. So I think what you have to do is you have to press to present maybe or something. I don't know. Probably that's why.
Well,
I agree with Nikolai. Your slides are not moving. I don't see them all.
Just press to enter presenting mode. Put it on a slide mode. Lower.
You can press F5.
Please press
F5.
F5.
Yeah, the functional buttons.
F5. Do you see them? What do you see now?
No, we don't still
No,
see.
sir, it's still the same.
Now does it move?
Or you can click on the left of 73% at the right bottom.
See, there is 73% there on your right corner, right lower corner, and next to it there is a small icon. Click on that.
Sorry, but I don't understand.
See your lower right corner of your screen. Do you see 73% there?
Yes.
So next to it, there is a small icon. Don't press that. Move your cursor now toward the left. That's it.
This
Press
one?
there. Yeah. Press there.
What do you see now?
Press again the same button that I was asking you to press. That one. No, don't touch the percentage. Just cancel that and press that
Yes.
small icon that is next to it. That one. Yeah, press it.
Do you see now the whole picture?
We see something moving, but you might need to move it.
There was a change in slides, but it's also not in full mode, and we cannot
So
see.
you can use page down button. If it's not enlarging, then you can use page down button only for changing slides.
Imad, can you please guide me?
Sir, you can use page down button from the keyboard to change the slides.
Okay. How about this?
Yes.
Yes.
Something is changing. Something has changed.
Now I change all the slides. Do you see now?
Yes, we see it changing. Yes. Okay. Carry on like that.
All right. So you have not seen anything of this, eh?
Not really.
All right. Anyway, I will present 2 or 3 of the old ones. So you can see here hyperlordotic lumbar spine with hyperkyphotic cervical spine, and you can see a kyphotic lordotic lumbar spine with a complete pelvic rotation backwards and hyperlordotic cervical spine, but with global kyphosis. Now, as I told you, it's very important to do the posterior facet because they are carrying 64% of the load in cervical spine, and it's important to have C1, C2 because it's 8% of the lordosis. And you can see here how C2 to C7 here, it's only accountable for the 23% of the lordosis angle, and the 77% is C0, C2. And you know the angles and how we compare the upper end of the sternum with the center of the femoral heads, the T1 with the center of the sacrum, the thoracic inlet angle, which is this with the pelvic incidence, and the neck tilt here with the pelvic tilt, and the T1 slope with the sacral slope. And we can see here, if you have a small thoracic inlet, you will have small lordosis. And if you have a high and large thoracic inlet, you will have large cervical lordosis. And it can be a regional deformity or a total cervical deformity that can cause also cervical myelopathy. SV chin brown to vertical, it's very important for the horizontal gaze, but it's very important for the improvement of the quality of life, and it must happen always with the hips and knees extended. Don't forget that. And the cervical SVA goes from the center of the C2 and the distance from C7, and you can see here the distance between C7 and C2 plumb lines. The clinical symptoms and natural history are interrelated between deformity, neurology, and pain. And sagittal plane is very important because it can be, when it's corrected, it can have the best clinical outcomes, and it's very important this. And it can also be associated the greater kyphosis to the greater neck pain. The anterior approach facilitates safe neural decompression. It's safer, and we have availability of lordotic and hyperlordotic cages and expandable corpectomy cages. It's easier for the surgeons and safer for the patients. And with deformity corrected anteriorly, additional deformity correction may be achieved posteriorly if needed, with more limited osteotomy. But for severe fixed deformity and for patients with osteoporosis, the anterior must be supplemented posteriorly. Art of surgery, it's the acronyms for aim. What is the aim of the surgery? What is the chief complaint? The physical examination? How is the global sagittal balance? And what is the best route? The route is how do you achieve that goal? Does anterior or posterior alone suffice, or should the circumferential approach be utilized? And the technique, it's the technical details that will make the surgery safer. We have 6 grades of cervical osteotomy resection. The number 1 is partial facet joint resection, anterior cervical discectomy, including partial unconvertebral joint resection, posterior facet capsule resection, or partial facet resection. Then we have the complete facet joint or ponte osteotomy, with both superior and inferior facets at a given segment are resected, and other posterior elements or vertebra, including lamina or spinous processes, may also be resected. Then we have grade 3, which is the first, which comes with partial or complete anterior corpectomy, including discs above and below. Grade 4 is the complete unconvertebral joint resection to transverse foramen, as was said by Ed Bensel. Grade 5 is the opening wedge osteotomy with complete posterior element resections with osteoclastic fracture and open wedge creation. And grade 6 is the closing wedge osteotomy with complete posterior element resections and pedicle resection and closing wedge osteotomy. Now, a cervical kyphosis can be caused because of craniocervical deformity, and we treat it with craniocervical junction osteotomy, or subaxial deformity with flexible in a younger patient and Smith-Petersen osteotomies, or fixed deformity, high to mid subaxial circumferential osteotomy grade 3 and above, or mid to low subaxial C7 or T1 PSO. Here we have new elements. In fact, with this great paper from the International Spine Study Group in 2019, which compare the relationship between osteotomy grade and vertebral level on alignment and clinical outcomes, and showed that patients with osteotomy in the cervical spine improved in T1 slope, cervical lordosis, and C2 slope, which is very important, as we showed before, and Ed Belzel said that. In the upper thoracic spine, multiple minor osteotomies, which are much safer, achieved similar alignment changes to compare with the major osteotomies at a single level. So you can do that ponte osteotomies in order to have the same, like a big corpectomy with complete posterior element resection. Now, the important thing is that, and the new change is that a major osteotomy focused at T2, not T1, had the greatest, or C7, had the greatest overall impact in cervicothoracic and global alignment in cervical deformity patients due to lever arm effect. From the paper, we can see that if we have T2 osteotomy and open wedge resection, we can achieve even 39 degrees, almost 40 degrees of lordosis. If we have T1 or C7, we can achieve only 15 degrees of lordosis. So it's very important at T2 to have a safer open wedge osteotomy and a greater lordosis result. This is a deformity with a great osteophyte causing myelopathy, and this is a grade 3 corpectomy. And we can see that the rest of the body and the facet is there, but we have a neural decompression and a nice lordotic result with a great opening at C3, C4. We will see how this will go in the future. This is a case that was operated, but in the above level, we can see here myelopathy above the instrumentation and great pressure on the spinal cord. We did that with Yannis, and you can see not a huge result in the lordosis, but a very good result in spinal decompression. And this is a case, I don't have the initial one, but it was a neural spinal cord compression and C6 to C7, it was sliding anteriorly and compressing, but it was a rheumatologic patient with great osteoporosis. So as you can see, in the thoracic spine, the screws are huge. In order to cross the anterior part of the vertebra, to have a very stable fusion, and then we have a big lordotic inclination at T1, as you can see here, in almost 75 degrees. Posterior cervical osteotomy should be a component of every deformity surgeon's armamentarium for the treatment of rigid cervical kyphosis. Appropriate patient selection, meticulous technique, and careful perioperative care are essential for successful patient outcomes. The treatment of cervical deformity is complex, but the principles are straightforward, obtaining a balanced correction that results in a solid fusion with adequate neural decompression by performing an operation with the least amount of surgical risk. Thank you very much.